Thank you for the invitation. It's a real pleasure to be here. Last year I gave a similar presentation. I know some people were here from last year, and I was happy to be invited back. That's always a good sign. So hopefully this will be well received. I think last year was the first year we had added a talk on lung cancer at this conference, and so obviously this is an area that's very important to me from the work that I do, and so it was a good opportunity to talk about lung cancer and lung cancer screening in particular. My name is George Genchos. I'm a chest radiologist at UVM. I'm the chair of our lung cancer screening program, and I direct our thoracic radiology program, as well as vice chair of radiology at UVM. The quick outline here, I don't have any financial disclosures. The quick outline is to build sort of a case for why we do lung cancer screening. There's, I don't want to get too deep into the issues and statistics. There's a lot of statistics in this talk, and I don't want to get too bogged down into it. There's a lot to say about it, and I'll try to make the case and then talk about specifically lung cancer screening and why I'm an advocate for lung cancer screening and what are some of the issues and barriers to screening. The talk is directed somewhat towards primary care providers. And can I just get a show of hands who's a primary care provider? So a good number of people, great. And hopefully it'll be relevant for everybody. And last year we had a really good discussion at the end. I had some really great questions. So feel free to interrupt me, or we'll leave some time at the end to talk about some of the issues that come up, because it's a really critical, particularly for the primary care community. So, whenever you talk about lung cancer, one of my colleagues is giving a talk later today about, is there a way to get the lights down just a little bit too, a little bit easier to see? One of my colleagues will give a talk about lung cancer that's not related to smoking, but there's really no way to sort of get around smoking and tobacco when you're talking about lung cancer. And this was interesting, I don't know if you can see that very well, but this is the equivalent. This was from Costa Rica. I was in an airport market, but this is their equivalent of a Surgeon General's warning. They put really graphic pictures of things that can happen to you from smoking, and I guess it's shocking when you see that, but it's sort of the equivalent of what their public health message is to try to avoid smoking. It turns out this type of stuff may not be very effective. But the point is really to draw out that, when you look at smoking, just smoking itself, it's a public health epidemic. Almost 500,000 people die a year related to smoking. And that includes lung cancer, it includes COPD, it includes coronary disease, it includes strokes, it includes other cancers. So again, this talk is not about smoking, but I do want to reiterate that, the strategies that we have for lung cancer primarily are geared toward either keeping people that have quit smoking from smoking again, or to get people to stop smoking or never smoke in the first place. So I hope that comes through in the talk. And in no way do I want to disparage smokers. It's tobacco is a very highly addictive. It's a legal medication. It's prevalent in our society. It's not going to go away. So again, this is something that we just have to deal with, just like car crashes and gunshot wounds and things like that. So specific to the women's conference, lung cancer is sort of an equal opportunity killer. This is a little hard to see this slide, but basically the top part is incidence of cancers in general, and then this is deaths related to cancer. And prostate and breast cancer are more common in men and women, but lung cancer kills more people than both of those diseases. And there's some numbers here, but basically if you look at cancer deaths, it's hard for me to see this, but if you look at lung cancer in men, it's almost 90,000 men die a year from lung cancer. In women, it's about 72, 75,000 a year. These statistics were from 2014. So it's a deadly cancer. It kills more people than breast cancer or prostate cancer, which are more common cancers. So it's really relevant to talk about, particularly in a women's conference, because it's killing twice as many women than breast cancer is, and we have some new tools to deal with it. So roughly, if you look at Vermont, we have about 500 new cases of cancer a year. 350 people roughly a year die from lung cancer just in Vermont, very small state, 500,000 population. So this is just a little background on the relationship between smoking and lung cancer and highlights the public health issue of that. The graph is a little complicated. In blue here, this is the sort of the rate of smoking over time. So starting back in the 1920, 1930, the rate of smoking really increased, kind of hit a peak after World War II, and then kind of declined a little bit. In the 60s was when the Surgeon General came out with the warning. The science was pretty good to say that there's an association between smoking and lung cancer. And then you sort of had all the public health issues that came up after that to try to curb smoking. So you had bans of advertisements, you had cigarette taxes that were increased, public health warnings and campaigns. And so the rate of smoking has gone down. That's been a success of some of those campaigns. Parallel to the smoking rise, this is the rate of lung cancer. So as you can see, there's a lag period of lung cancer. This is about 15 to 20 years that you see a difference between when people smoked heavily and when they developed lung cancer. And we hit the peak of that about the year 2000, 2001, and the rate of lung cancer has gone down a little bit. That parallels this curve almost exactly. Just for comparison, this is the incidence of breast cancer up here, which has stayed relatively steady and then has come down a little bit. So lung cancer, obviously, it didn't used to be this common, but now it's much more common than breast cancer as far as this is cancer deaths. So if you look a little bit towards the more modern era, this is men and women. So this is lung cancer incidence by sex. They said it peaked and it's kind of gone down. Men's rate of cancer has come down a little bit. Women's really came up, and they're almost at the same rate now. We see lung cancer a little bit more in men than women, but it's very close. Again, both are coming down a little bit, so that's a good news as far as the public health component. Yes? Yeah, so there are some different theories on sort of the rates of that. It's interesting that it's a complex question, but some of the filters that were put in, that was really one of the big changes. And there's no good evidence that filters prevent lung cancer. In fact, some people think it actually is the same or increased relative to filters. That's been sort of the big issue. There were other additives that were in tobacco that may have been also causative. Some of those additives are less common now, but the rate it actually hasn't really changed much when you look at compared to the percentage of smokers. The big issue now is vapor. Are e-cigarettes are as dangerous as cigarettes, and we don't have the answer to that yet. So it's another thing that we'll find out. All right, so just to summarize, lung cancer is the most common cause of cancer deaths in both men and women. We have about 250,000 new diagnoses of lung cancer a year. 150 to 160,000 people die a year from that. And the bottom line is that early stage lung cancer is curable, but most patients now don't present at an early stage where it's curable. At our hospital, we see about 200 to 300 new cases a year. Most of what we see presents in later stage. So that's really the problem. And so when you look at a screening test, one of the big issues of deciding to do a screening test is the disease, first of all, is it a public health problem? And I would argue this is one of the biggest health problems. We're seeing 500,000 people dying a year from smoking-related diseases. Lung cancer is the most common cause of cancer death. Yes, that's a big public health problem. The second thing is there an intervention that you can apply to the disease that can improve the cure of the disease? And so lung cancer, yes, you can say yes to that. So it's a good target for a screening test because there is a curable treatment in an earlier stage. So then the issues come down to the test that you use, but it certainly meets the criteria for and to amplify that a little bit, if you look at the 5-year survival rates, this is based on data between 2002 and 2008. This is the overall 5-year survival rate for any stage disease. Lung cancer is really one of the worst cancers, probably only is second to pancreatic cancer for its 5-year survival. So only 20% of people will be alive after 5 years. That's very abysmal, mostly because it's late stage disease that's detected. And you contrast that with colon cancer, breast cancer, prostate cancer, very good 5-year survival rates. Now these are diseases that there are screening programs for, so that does influence the 5-year survival for sure. But to highlight the point of this 5-year survival by stage, when you look at stage 1A, which is the earliest form of detectable lung cancer, 85% of those people will be alive at 5 years with pretty good therapies. So, and you get to stage 4, it's less than 2%. So this shows that curve. So it's really important to detect early disease. That is the point. this is what our experience was from 2008 to 2012. We had formed a lung cancer clinic specifically for lung cancer, and blue is men, pink is women, and this is the stage of disease and the number of patients. So we were detecting a lot of people at stage 4 disease. That's when you get symptoms. You get blood in your cough, you lose weight, you don't feel well, and you find out that you have late stage disease. We weren't picking up a lot of people. We didn't really have any type of screening test during this period, so we weren't picking up the people with early stage disease. So the basis of screening is this large study that was done. It basically ran from about 2002 to 2006 when they were accruing patients, doing the tests, and then there was an analysis period and a sort of a period where they analyzed patients, and then the study was published in 2011. But this was the National Lung Screening Trial. It's one of the largest prospective randomized trials in the United States. So the science of the test was pretty good. It was well controlled. There was 2 arms to it. There was a group of patients, 26,000 patients that got a low-dose CT scan, and then a similar group of people that got an X-ray. And these were all high-risk patients. So they had a significant smoking history. They were age 55 to 74 years. They had smoked at least 30 pack years, quit less than 15 years ago, so pretty high-risk patients. And so basically they got 3 years of screening on an annual basis. And then there was a data accumulation period. So this is a very complicated study. It has its proponents and its advocates who have questioned the results as far as the applicability of the results. But what the study showed was that if you look at the group of patients that were screened with low-dose CT scans, in that group there were 346 deaths. And if you looked at the patients from lung cancer, if you looked at the patients who were screened with chest X-ray, there were 425 deaths in that group. So if you do a little bit of statistical manipulation with that using something called the person years, which is the number of years someone was in the observation of the study times the number of people in it, the relative reduction in mortality between these, in the cancer death rate between these 2 studies, given the person years, was a 20% reduction. Translated to mean that if you were in the screening group with getting a CT scan, you had a 20% less chance of dying from lung cancer. So that was felt to be very significant. There have been other smaller trials looking at this and comparing chest X-ray to no screening, some smaller studies looking at CT scan compared to either no screening or chest X-ray, but this one was the biggest one, and it would certainly showed a sizable effect. I'll talk a little bit more about the relative risk at the end because there's other ways of looking at this. Yeah, great, good. You're paying attention. So this was the problem. This is one of the big criticisms. So, if you looked at the number of tests that were positive, almost a quarter of these had a positive test, and most of those were not cancer. They were false positive. 96% were false positives. Chest X-ray, it wasn't as often positive, so you didn't get called back and say, oh, you have to do something about it. And those, even when they did, that also had a high false positive rate. And I'll talk about that because it's a very valid criticism of doing it across the nation, but there's also ways to get that down and to dive deeper into it and figure out what are we talking about specifically with false positives. Good. Everyone pay attention. If you can point out something interesting on a slide, you get some kind of prize, right? All right. So again, this is the complex statistics here, and I'll get out of this pretty soon. So lung cancer, so basically this is the results of the trial, looking at it in the same tabular way that we looked at our own experience at UVM. So now, CT is in red, X-ray is in blue. So now if you look at these, this is stage 1A. So now, CT was picking up a lot of the earlier stage. It's a more sensitive test. You can see smaller lung nodules. So you're flipping that curve of, okay, you can detect more disease at an earlier stage as opposed to the later stage. They're both really good at picking up late stage disease. The middle stages have some challenges, but you can really pick up early disease here. And so that was the point. We do have a test now that actually can pick up something at an earlier stage. So this was, after 2011, there was a lot of public health discussion. The U.S. Preventive Health Service, USPSTF, is the government agency that decides on screening programs. So they reviewed it, and they came up with a what's called a grade B recommendation. So a grade B basically says the science is pretty good. We recommend this test. It was largely based on the results of that screening trial. They noted some things that they were concerned about, which was the high false positive rate, some potential for harm. They broadened the eligibility a little bit, so they made it 55 to 80 years. They kept the same smoking risk factors, so it's still high-risk smokers. This was, after this, there was Medicare reviewed it, and they've also approved it for Medicare patients. And I'll talk a little bit more about the insurance issues with that, but that's the current state, as it's approved by the USPTSF, it's approved by Medicare for general screening. So with any test, you can talk about with any screening test, you can talk about pros and cons. So we talked about, screening test is supposed to have a disease that has a significant public health concern. It should have an early treatment that improves survival. The test itself should be low cost. It should be easy to access. And so when you look at the test itself, you can make some arguments for and against. And when you're in this field, you kind of have to come out on one side or the other. I'm on the pro side because this is what I do. And I believe in it, and my experience is particularly jaded by seeing a lot of late-stage cancer patients where we didn't have a lot of options, and now we're starting to impact the disease, I think. So, you can reduce cancer deaths, you can detect early stage, it's a safe, non-invasive test. There's minimal need for biopsy. Most of the times we can sort things out without a biopsy. And a lot of times we find other things on a chest CT scan that's significant to people and their livelihood. Cost is an issue, the high false positive rate. It causes some anxiety, although it can also decrease anxiety that you have lung cancer. You do have to work up some incidental findings, and there is some radiation exposure. So you can make some arguments on both sides. Yes? Say again? I'll get into that. It varies across the country, and I can talk a little bit about it here, but there's no one answer. It varies across the country, and I'll talk about some actuarial data. It varies by payer, basically, so it's pretty complicated. Yeah. You're going to pin me down. Say again, I'm sorry. Yeah, so complicated question, if you're, theoretically, if you're purposefully not insured, there is an out-of-pocket, I can give you some quotes on that. There's a discounted rate for a self-paying rate. But theoretically, if you couldn't afford insurance, you would be covered by Medicaid, and that has a government rate associated with it. So it's a complicated issue. I can talk more about it at the end. So basically, we acknowledge that there's controversy around this subject. On the people who were involved in lung cancer, particularly, we were very pro-screening. We thought it was one of the best things to happen in our field, particularly for lung cancer. But we have to acknowledge that there's some limitations of this test. And so we formed a screening program at our hospital really to address these concerns and to have a really cogent, helpful system where we're applying the results of this in a useful way, involving patients, involving primary care providers. So that was a sort of a task force that we put together. Now we have a fully functioning screening program. Our goal is really to provide safe, effective lung cancer screening, really help the primary care provider facilitate this process because it's complicated. You're kind of caught in the middle between the patients and getting scans. And I'm reminded, Carolyn Reed was a relatively famous chest radiologist in our small world. And I like this quote of hers. It says, when you have to realize when technology is a hindrance, not a help. Test machines and procedures cannot supplant listening, experience, and intuitiveness. So, what we didn't want to see was that a test is just going to be out there and there's going to be no explanation, there's going to be no guidance, there's going to be no people sort of guiding people through this process. And that's what our program is about. It's a nascent program and we're building it. We're a very small group of people, but I think we're very dedicated to making a better product both for our primary care practitioners and for the patients. And so it's a work in progress for sure. In that regard, we have, patients get a lung cancer screening CT, but it's tied into other medical areas. So we have a lung cancer clinic. It's a multidisciplinary clinic to deal with all the issues that come out of people that have positive results. We have a lung nodule clinic that my colleague, Dr. Garrison, who's a pulmonologist, set up for people that if a primary care provider wants to refer someone to a clinic, whether they have concern about a nodule or to take over the management of that case, that's something that we set. Smoking cessation is a part of this whole process. So both when patients come to get their CT scan and then at the primary care office. And then we have a specific follow-up program that we're building to, just like with mammography, to send letters and give patients direct results. I have a lot of sort of bigger ideas how we can improve our processes and improve our presence when patients are getting their CAT scan, but that's been a little bit limited by staff right now. I have one coordinator who's a half-time person, and it's pretty limited resources that we have. Our facility did receive this designation as the ACR, as the American College of Radiology. It recognizes a center as having expertise in screening and management of lung cancer. So one of the arguments of the trial was that these were all done in large academic centers, and if you were to replicate this across the nation, the quality would go really far down and you wouldn't get the same results. And so this is one of the avenues that a center can apply for this designation. It recognizes expertise in interpretation, scanning technique. It has ongoing accreditation. So this is something that we did, and it certainly is an area that we were very familiar with. Part of the standardization process, and for the primary care providers who may have seen some of these, so part of the screening technique is that you use a specific lexicon in your reports. It's very similar to mammography where there's categories. So this is a sample report, and this is the type of categories that we have. So there's basically 4 categories and a couple of modifiers. The reports are a little confusing, but in it spells out everything that you need to know. So, and I will show some examples just so people are familiar with it. But what it really does is it forces the radiologist to really characterize their degree of suspicion. You have to give some recommendation, just like with a mammogram. And so that takes the guesswork out of it. You know, certain categories have certain specific follow-ups. And so it's a relatively helpful system because you don't have as much, there's no hedging, there's no less doubt about what to do with it. So it's pretty useful. We've expanded our program to include Central Vermont Medical Center. Those scans are done there, and then they're interpreted here as well. So I want to show a couple of cases. These are all CT scans of patients that were scanned here. I'm just talking about the categories. So we have this category 0. So basically category 0 is when you can't evaluate the lungs because of something else going on in the lungs. So this is a patient that came in and all these nodules and mass-like opacities, this is areas of pneumonia. So the patient can't be, they came in for a screening and they have pneumonia in their lungs. So you can't really make a good assessment of is there cancer here or not. So there's different ways of dealing with this. We usually have, we tell the provider that they have pneumonia. We can't really do a screening exam with this test. Usually they'll treat them for pneumonia depending on if they have symptoms, and then they'll come back, usually in about 2 to 3 months, to repeat the screening examination. So that's happens periodically. It's not very rare. Modifier S is a significant incidental finding that we see other than lung cancer. So this is a patient. So this was a mass in the right breast. This is a discovered breast cancer in someone coming for lung cancer screening. It was a local non-advanced lung cancer, and she's currently undergoing therapy for that. So sometimes you pick up pretty significant incidental diseases on these scans. This is sort of one of the problem areas. So category 3 is when a test is considered positive. So the 1s and 2s are basically negative tests, and the category 3s are positive. So this is the type of nodule that we see occasionally. It's sort of mostly a solid nodule, has a little bit of ground glass component. We have certain size thresholds that put them into different categories. So with this size threshold, this went into a 6-month follow-up, and the nodule actually got a little bit smaller. It's still there. So this is likely a benign tumor. Benign region of inflammation. It's not a malignancy. So this is something that after this scan from category 3, it would be downgraded to category 2, and then they would get yearly follow-up after that. So this is when I talk about positive and false positive results. So the sequela of this positive test is the patient got 1 extra scan and then would go back into screening. And this is really the majority of our positive tests are these categories. They don't need a biopsy. They don't need a PET scan. They don't need a CAT scan every couple of months. This was 1 extra scan. So that's the majority of our follow-ups. This is a little bit more difficult thing to deal with. So this is a lower portion of the chest. This is one of the airways. This is the bronchus intermedius, which is the airway supplying portions of the lower lobe and middle lobe. And so there was a mass present within the airway. So this is characterized as a 4A. It's an endobronchial lesion. This is some reconstruction that you can do from the CT scan. It's called a virtual bronchoscopy, and this is the lesion here. So these are a little problematic. There's different ways to deal with this. You can do a short-term follow-up. Sometimes all this is just some mucus within the airway, and when they come back, it's cleared up. But sometimes these can be endobronchial tumors. And so you could either have a pulmonologist look at it with a bronchoscope and biopsy it, or you could have them come back. This one was a benign one. So this was a 4A nodule. So this is the nodule in the left upper lobe. It was, so the 4A category is between 8 and 15 millimeters. This has some suspicious features. And we wound up doing a PET scan, and the PET was positive, and then had a biopsy, and this was an early stage lung cancer. So this is really the situation that the test is really good for. This can be treated either resected if they're not a surgical candidate. We can do stereotactic radiation or thermal ablation. The cure rate is very high for this. Is a 1A lesion. So this is sort of what the whole test is about. This is another example of a nodule. This one was a little bit bigger. It was about 16 millimeters. It had these mixed attenuation. It was in the 4B category because of the size threshold. It just crossed the size threshold. So for 4B, you usually want to do something about that. So I read this case and I was concerned about it. You could do a PET scan and see if it's hot on PET. What we did was we did a short, we basically set the patient up for a biopsy in a short interval, about 6 weeks after that. But we do a scan before the biopsy. And on the scan before the biopsy, the nodule resolved. It was an inflammatory nodule, so the biopsy was canceled. So there's other ways of sort of doing that. And if something persists, you can do a biopsy if you need to. So that was good news. This is one of the 4X category, the ones that are they're cancers until proven otherwise. These are lesions that have cystic spaces, ground glass opacity, solid components, spiculations. Those are malignant lesions. This was another 4X category when there's other suspicious findings. So this was a mass in the left upper lobe. And then on the low-dose CT scan, there's some lymph nodes in the mediastinum. These are the periaortic and AP window lymph nodes that are enlarged. Those were PET positive. So this is the PET scan here. So this is the PET uptake within those nodes. So this was a patient that had a lesion in the lung, but they had metastatic lymph nodes. So this is a stage 3A lung cancer. There are surgical treatments for this, so we do treat some of these patients with surgery. We'll have the lobe resected. They can remove these lymph nodes at the time of lobectomy. So they're still a surgical candidate, but it was a more advanced stage. I think I'll skip this as a long slide. The point is that we have sort of pathways for different categories. What we try to be helpful, the 1s and 2s basically just get a follow-up in a year. They'll see their primary care provider. They'll get a letter. The 3s, 4s, and 4s need some further management. So our goal is to try to help guide that management, either in direct communication with the primary care provider. We have a pulmonologist that kind of keeps track of these too, make sure people are getting to the right place for these. Like I said, it's a nascent program. We're really trying to improve the flow of this. Again, this is my partner, Garth Garrison, very helpful with the management of this. Brent is the coordinator of the lung cancer clinic. You can always reach me. Lorraine is Garth's assistant to set things up. But if you have any question on any reports, insurance issues, if you just reach out to me or Garth or Brent. So that's the sort of the first half of the talk. And now I want to just talk about some of the issues of the test. Are there any questions at this point? I don't want to dodge your cost question.
How often are you following up? Is it yearly, like 1 or 2?
Say again?
You're following up yearly for how long?
Yeah, so I'll talk about that. So basically, and I'll talk about that with the risk. So it's an annual test, and as long as the patient's in the screening range. Yeah, and I'll talk about why we do that. It's really important actually, and it's a good question. How do you order it? There's a PRISM order. You put in lung cancer screening. There's a questionnaire to fill out. Part of the issue, and I'll talk about it a little bit, is for the Medicare patients, you have to do a shared decision-making portion of that. We have to prove that that was done to do the test, and so we have some questions about that they're to attest that a shared decision-making visit was done, and I'll talk a little bit about that. So who do you order for now? So the USPTSF says 55 to 80. Medicare covers up to 77. 30-pack history, quit 15 years ago. Annual screening while the patient remains in the high-risk group. So even though the trial was for 3 years, we recommend that people stay with annual screening. I'll talk about that. So they can't have signs or symptoms of lung cancer. So basically hemoptysis, weight loss, that kind of thing. Cough is not, unless you think it's cough related to acute illness like pneumonia. But COPD-related chronic cough is not disqualifying for doing the screening. These are the Z codes for ICD-10 for screening, tobacco use or for screening for lung. Say again. Yes, definitely, yeah. No difference, yes.
So anybody who's quit smoking more than 15 years ago,
Yeah.
they don't feel that that's really worth it.
Yeah, it's not, you're in a less, I'll show some of the data on that. You're in a less high-risk group than the people, so it's trying to get the highest risk group. Now, you stay in a high-risk group despite, if you quit less than 15 years ago, and it's a really good question. I'll talk about, what happens if people fall out of this recommendation, what are some of the options? And there are some options, I think. So the insurance, so all, under the Affordable Care Act, all insurance that wasn't grandfathered under the Affordable Care Act should provide coverage without a copay or deductible. That's mandated by law.
What about other forms of tobacco use other than smoking?
No, it has to be tobacco, yeah.
No,
I mean,
smoking.
cigarettes. Yeah, it says smoking cigarettes. If you had the same pack year with pipe or cigars, you could probably just say smoking for this long. The risks are probably relatively equivalent for that duration. Medicaid covers it, but there's a it's set by state policy, which follows federal policy. On the lung.org link, there's a really good section on this screening, which plans cover it, which don't. It's worth taking a look if they're for specific issues. The only thing that I've noted, there's two issues that come up with the screening. Is one, as someone mentioned, what if someone doesn't fall within the range of screening? Let me just talk about that briefly right now. So the issue with, if you think someone is high risk and they're not in that very select group of high risk patients, you can order the test. It may or may not be covered. My suggestion on that is to put as much evidence as possible why you think they're at high risk, adding additional risk factors. They had, family history of lung cancer, they had exposure like asbestos, and there's other ways to sort of bolster your claim that this patient is at high risk. The bottom line is that insurance might deny it based on that strict application of the numbers. Shared decision-making, this is I just put the slide so you can just see, this is from the Medicare page of all the things that have to go into a shared decision-making visit. So they approved a visit for this, where a patient can come in specifically for this purpose, to talk to them about lung cancer screening, make the decision, is this right for me? And so the documentation part of that is that provide smoking cessation opportunities for someone who's currently smoking, use some type of aid to talk about their personal risk and whether they should undergo lung cancer screening, make sure that they're a good candidate for screening, that they would be able to be treated, et cetera. And then you have to furnish a written order. So that is, they wanted to make this part of a discussion, and I think that's actually a good thing that they made it a paid visit where specifically for this purpose and talk about the issues.
Is that outside of the annual wellness visit?
It can be both. So if you could add that, so it can be a specific visit for this if you meet those documentation requirements and that's for Medicare patients. Most of the private payers don't have this, but I'm sure they'll follow suit at some point. On our side, I didn't put a slide in here, on our side, Medicare patients, we have to also provide smoking cessation counseling. We have to verify the medical decision visit was performed, that documentation is available for audit on our side, and then we have to actually enter all these patients into a national registry. It's pretty time consuming, and we're just getting started with this with our limited resources. So they've made it very onerous, but Medicare basically has decided that, yeah, we think this is a good idea, but we're going to collect a lot of data on it and then sort of use this as a continuing experiment, which is very reasonable. So one of the big issues with any screening program is people have to buy into it. Patients have to buy into it, and providers have to buy into it. And I'm going to talk about that for the next about 5 or 10 minutes. So if we look at different screening tests, we don't have great compliance rates with a lot of screening tests. Cervical cancer was pretty good, 83%. This was data from looking at 2000 to 2010, just rates of screening and their applicability. Breast cancer was pretty good. There's a lot of data out there. There's a lot of promotion of breast cancer screening. Colorectal cancer was not so good, but was trending upward. So this is about 3 things. It's about education. It's about buy-in, both from patients and from providers. But even within, you don't capture everybody. There's people just not going to get the opportunity to be screened. Risk. So I think this is the biggest thing that I want to talk about. So I don't know if you guys heard about this, the dangerous selfie. It highlights an interesting foible of humanity, is that we have this sort of eternal optimism that isn't often realistic. Yeah, exactly. So, this is it's a good example of that, with sort of people taking pictures of themselves in dangerous situations, of just sort of saying, okay, is this like a really wise thing to do right now? And I think this one was fake. I think this one is real. But I saw this when I was putting this talk together last year. There was a news show in Russia. It's like an epidemic of people dying from these dangerous selfies, and I saw this. They put out this pamphlet of like, okay, these are things you shouldn't be doing. You shouldn't like hold a gun to your head and take a picture of yourself. Don't climb, don't take pictures of yourself on stairs, or some of these are incredible. It's like the boat one, the dangerous animals standing in front of a train. It's like those aren't good ideas. But it highlights that we do have this sort of are we good at assessing our risk? Not particularly. And the flip side of that is, can a doctor, are they good at telling you your risk? And, there's some evidence that, we don't often, confront people with their risks. It's a little bit something that we don't do. And this is just a slide to kind of show that a little bit. This was from a study done in 2005. Basically, it looked at a questionnaire, asking patients what their risks were, and then sort of comparing it to their actual risk. So this is basically, this if you smoked more, and this is the relative risk. So, patients understand that they're at risk for lung cancer. They don't really understand what their actual risk is. So this is sort of what people perceive the risk to be, and this was the actual risk. So, heavier smokers kind of gave the same answers to lighter smokers and didn't really understand that was connected. This is a really important slide, and this goes to why we do annual screening. So if you're a non-smoker, so this is your age, and this is the death rate per 1,000 for lung cancer. So as you go, if you're a non-smoker, your risk of lung cancer is extremely low. We do see lung cancer in non-smokers. But as you get older, you actually, you're exposed to more toxins, and some people do get lung cancer, and that risk actually goes up a little bit in non-smokers as you get older, just like all other cancers. So this is the smoking curve. So if you keep smoking, your risk of developing lung cancer goes up, and it's not linear, but it's a steady increase. So this is the age at which you stop smoking. So you can get off this curve when you stop smoking, but your line sort of parallels a non-smoker. It still goes up a little bit. So I think the misconception is if you stop smoking, your risk drops down to here, or your risk is 0. And that's just not the case. Your risk stays pretty high, and it's actually still going up a little bit. So this is why we recommend annual screening. So in your 5th year of screening, your risk of lung cancer is actually a little bit higher than it was in your 1st year of screening.
Just because it's 5 years later.
It is, yeah. It's just time, and right, exactly, yeah. So I think that's important. And then you look at people's sort of perception of this. 7% of smokers felt they were at risk for lung cancer, non-smokers. So non-smokers in particular, former smokers. So if you quit smoking, there's a real fall off of what the actual risk is from cancer. So there's different ways of looking at risk, and I wanted to bring this up. So this is one of the models that people are using more, because when you talk about relative risk, what does that mean to someone? Like, oh, there's a 20% reduction, and if you were to get a chest X-ray as compared to a CT scan, it doesn't have really a lot of significance to someone who's actually getting the test. So people are promoting this sort of risk characterization theater. So basically, present it in something that you can understand, applicable to you. So this is a theater filled with 1,000 people. And so if you highlight spaces within that theater, it gives people a visual reality of what their actual odds are to develop the disease. So this one is people, so this is 1,000 people being screened for lung cancer. So you have to set the scenario. So that's the important thing, is to say, okay, here's the scenario. So if you took 1,000 people, put them in a theater, and you screened them every year for lung cancer for 3 years, this mirrors this is how many people you would find cancer within. So that's about 10 people, roughly. Of those 10 people, the black dots, those are the people, it's 3.5 dots, those are the people whose life you're going to save by screening. This is the false positive rate. So this, again, this is based on the screening trial. So this is basically a 21% false positive rate or 22% false positive rate over the course of 3 years. This is, and I'll talk about this, this is actually half of what it is when you use different criteria. But, so if you present this to someone, say, okay, this is your chance of having lung cancer, this is your chance of having a positive test. Someone might say, whoa, I don't want that. I don't want to be scared. Or they might say, yeah, definitely screen me. That looks pretty bad. There's a couple of spots there. So it's a visual representation of it. I want to give a couple of other examples because it's pretty interesting when you present things in this way. So this is breast cancer screening. So if you filled a 1,000-person auditorium and screened patients for breast cancer throughout their life that they're eligible for screening, so those 1,000 people, you're going to save 1 life over the lifetime of screening. So that doesn't sound very good. And when I look at that and I'm in the lung cancer field, I'm like, whoa, that's pretty, we have a pretty good success rate. And so that's another way. And the false positive obviously looks pretty similar to lung cancer. But just, it's another way of looking at the data. I don't mean to disparage lung cancer screening. I think it's really important. But, it's a different disease than breast cancer screening is a different disease than lung cancer. So this is something else I thought was interesting. So we look at cholesterol. Like we look, cholesterol is a big risk factor for. So if you filled 2 auditoriums, so if you took 2,000 people that had high cholesterol, defined by 210 to 250, so there'll be 1 death per year compared to 2,000 people with a lower cholesterol level. So it gives you a sense. And this is something we sort of target and spend money on because it's important, right? 1 person dying is important. This is one that I like. This is smokers. Don't smoke. This is a good example. So if you took 1,000 smokers and followed them for 25 years, if they stayed in the theater, there'd be 198 extra deaths compared to an auditorium of 1,000 non-smokers just from smoking. And that highlights the epidemic of smoking, where 500,000 people are dying every year. So you look at this chart and you're like, wow, that's really, that's impressive. A lot of extra people die from smoking. Cost a little bit. I want to talk about this is an issue that comes up, and to talk about specific costs. So there was supposed to be a very extensive analysis of cost from the lung cancer screening trial. It turned out that was extraordinarily complex because in addition to the cost of the screening, which was actually fairly simple, the additional costs that were incurred by sort of the management of nodules, biopsies, treatment, that information was colossal, and they wanted to present it sort of in a cogent and thorough manner, and that has not been published yet. There's been some sub-analysis of that data, so it's not out there yet to sort of analyze and look at. We know it costs something. We know it's expensive. This was a paper that came out after the lung cancer screening trial. It's an actuarial analysis. So they took Medicare data. I think this was from the year 2014. And they basically applied the lung cancer screening trial results to the Medicare eligible population. And I should have highlighted a couple points. It's too hard to read here. But so the cost of the screening, and this was an average cost of the nation, it's about $250 if you average national cost to get the test done. So that includes the CT scan and the interpretation. So that comes out, there were about 4 to 5 million eligible patients that would have been eligible based on their smoking history from the Medicare data to get screening. So the cost of that would have been $1 per month per person if half of the people got screened. So that was one thing. So they felt that the cost of that was pretty reasonable just for screening. And then they figured out how many people would have, they used the survival data from the screening trial to say how many people would have survived in the Medicare population. They found that they said it was cost effective per year life. So it cost about $19,000 to save someone's life for a year. So that number, it sounds really high, but it's actually, it compares very favorably to other screening tests, which can be in the range of $30 to $40 to $50,000 per year life. The really interesting thing about this is they applied this, so they said if this group of patients in 2014, if they had been eligible for screening, this 5 million people, if they had been eligible for screening starting at age 55, it was almost 400,000 of them would be alive. So that's a huge number. And again, they said that the screening test itself is cost effective. Now, the other issue with cost is, do you save money by detecting earlier cancer? We've looked at this at our institution and just looking at the costs. It costs about $50,000 to $60,000 to treat someone for stage 1 lung cancer that has surgery. The cost of stage 4 cancer, we just looked at an average of it. It was somewhere between $200,000 and $300,000 to treat stage 4 cancer.
And
So,
they're gonna die.
well,
So,
yes,
I mean, they're gonna die earlier, obviously,
Right.
we're all gonna die.
Yeah.
But, I mean,
Right. Yeah, the prognosis is definitely better.
$400,000
Yeah.
and
right. The outcome might not be good. Yeah,
you're gonna get
absolutely.
your outcome.
Yeah. So the other issue of cost that I like to look at, and so to answer your specific cost, our hospital has like every hospital has a paymaster that they have for every test in our hospital, every procedure, every service. They have a charge to it. They negotiate each of those with each individual payer. So it's a pretty broad range of payment schemes. So it's hard to pin down a specific number. On average, it's somewhere between $200 and $300, but in some cases it's more depending on the payer, in some cases it's less. The big issue is, there's a lot of money coming in from tobacco. So just to spend a few minutes on that, so if you look at the price of cigarettes, this is a scale in dollars over time, the price has shot way up. Some of that is related to cigarette companies raising the prices and a lot of new taxes. And so why did cigarette companies raise their prices? Anyone know? Yeah, they can, and they were charging. They're paying the states to take care of patients that have smoking related illness. Yeah, I talked about that. So they were paying the states extra money to administer the master settlement, which we'll talk about. So what they did was they just raised their rates, so their profits stayed high. So that's so this is. Let me just go to that. So this is the money that comes in from taxes and from the master settlements. The master settlement was in 1998. It was between the attorney generals of every state and the tobacco companies. So they give money distributed to the state every year. So it is, yeah, that's in perpetuity, basically. And so let me just show you that. So what comes in every year between taxes and cigarette revenue from the companies, it's $25 billion a year comes into the states. The CDC recommends that we spend $3.3 billion of that on tobacco control, smoking cessation. The states actually spend $490 million on it. So there's a lot of money coming in. And we're paying zero money basically for screening at this point. So that's, it's a target that you really should look at. When you look at this number, this is a huge number. The NFL generates $10 billion a year. The Star Wars franchise has generated $30 billion since 1977. This is a large number of dollars that come in. Now it goes to treat, it goes into medical programs, it goes into roads, it goes into salaries. That money goes all over the place. So the false positive rate, big deal. You don't want a lot of false positives. So they looked at data. So basically the threshold for a nodule was 4 millimeters. So if you cut that down, if you raise that to 6 millimeters, you really decrease your false positive rate to about 10%, or your overall positive rate to 10%. And so that's what we did. You can argue with the rationale for doing that because you've manipulated the results of the test. You've used the results to change the test, and so you can introduce bias that way. But that actually is really effective for decreasing the number of false positives, and you don't change the outcome based on the trial. So, that's pretty effective. You can potentially save a lot of money. And this actually turns out to be what our rate is. When we look at Cat 3 and Cat 4, we come out to about 11%. So we don't see a lot of positives generated. It's definitely not 27%. It's more like the 10 or 11%. What about anxiety, patient anxiety? There's different avenues for dealing with that. Obviously we'd like to take on those patients if they have a lot of anxiety about the results of their tests, either referring to pulmonary or or other processes, but we definitely would like to take on those patients that either have a result that they have anxiety about or would like additional counseling about the test. One of the big things is that, people getting screened, we don't do a lot of biopsies, and most of the biopsies that we do are positive, they're not negative biopsies, and so that should be fairly reassuring. Most of the time people will get some type of diagnostic test, either a CT scan or a PET scan. They won't have to have a needle put into them to diagnose things. Radiation is, I'm going to just quickly go over this. The scan is basically, it's 1 millisievert of radiation. Millisievert is a radiological unit that we use that has biological characteristics and also relevant to the region of the body where the radiation occurs. So a low-dose CT scan is 1 millisievert. You get 3 millisieverts of background radiation from cosmic radiation and terrestrial radiation. So it's 1/3 of the amount of radiation you'd get from just being on the Earth. If you,
Is that in a year?
it's in a year, yeah. So 1/3 in one scan versus a year. That's the equivalent of about 7 transatlantic flights. Yeah, exactly. Yeah, so it's low dose. We feel like this is negligible radiation dose and should not have any biological risk, even getting it every year. So the data is actually pretty good on that doesn't cause problems. I'm not going to talk about this. So we talked a little bit about this. What if the patients, are not in the guidelines, but they really want to get involved with screening? So there's additional risk factors. Family history is a big one. Pulmonary fibrosis is a risk factor for lung cancer. Different exposure histories, particularly asbestos, some other occupational exposures, a history of prior lung cancer, prior chest radiation. So if you have another risk factor, my sense is if someone is really pushing this, I'd have him. My colleague, Dr. Garrison, I hate to keep bringing him up. He's busy enough already, but he really wants to take these on, and he would be happy to talk to someone. And sometimes it takes some additional legwork on the insurance end to say, this is someone that's really high risk. They really need to be screened. So that's that, and it's problematic. If you ever have insurance issues, I'm glad to take those on as well, because the follow-ups and the recommendations are based upon American College of Radiology, lung RADS follow-up criteria, and most of the insurance medical directors are not familiar with them, so I've had a couple issues with that. But if there's any specific insurance issues, someone gets denied, if we're notified about that, we can help with getting it set up. Yes, ma'am. Yeah.
Think they've been exposed, but it's not really clear if it's real.
Yeah. Yeah, so you can start with an X-ray. X-ray is not, if they have a significant amount of asbestos, you can see it on X-ray. It's not as sensitive as CT scan. And if there are specific concern, again, if you put in, asbestos exposure as the history and, theoretically there should be some symptomatology associated. Yeah. Yeah, yeah. So there's other issues. If they did have asbestos exposure, they would be at risk for lung cancer and interstitial fibrosis. So, there are other issues that could come up with. So someone with that exposure history, particularly if they're symptomatic, they have, shortness of breath or exertional dyspnea, whatever, that might be an indication to do a CAT scan. I'd probably start with an X-ray just to see what it shows, but the CT is more sensitive, basically. So, yes, ma'am. Yeah, it's based on extrapolation from nuclear bomb survivors from Nagasaki and Hiroshima. So there have been models based on that can show a theoretical risk, but that was based on a single massive exposure. So they've extrapolated those, and there are risk profiles that are generated based on that extrapolation. The other known one is that there are some risk models based upon, for instance, there's been association with young kids that were frequently got X-rays for scoliosis, and there was correlation with heavy X-ray exposure with certain malignancies in that population. The other one is sort of higher doses for treatment patients that had ablation for acne or for thymus or whatever. They're linear based, but usually based on very high doses. There's not much good evidence on low diagnostic doses, so we don't think that those linear curves are very effective at judging whether there is and there's something called stochastic and non-stochastic properties of radiation. So it takes a certain energy to break DNA, and diagnostic X-rays usually don't do that. What's that? Exactly, that's what I mean. So CT X-ray doses are usually pretty low, and particularly for this examination. So.
Is our hospital starting, I know the hospital partners in Boston,
Mm-hmm.
they're starting a program that keeps track of patients' radiation exposure with their different tests.
Yeah.
In that bucket.
Yeah.
So that over your lifetime now, that
Yeah.
start, really
Right.
knowing.
Yeah, we're in the process of doing that. We're adopting a program called Radiometrics, which tracks patients. So there are certain patients, particularly patients that have been diagnosed with cancer, which get a lot of repetitive scanning, and so that's something we'd want to be aware of. I think I'm getting the signal. Okay, great. Oh, that's okay. Thank you.